Hello everyone, and welcome back to UWorld's Next Generation NCLEX Review. My name's Rebecca, I'm a nurse here at UWorld, and we are going to be doing a lecture on maternal health today. So this is going to be content for antepartum, we have delivery and care of the newborn, and then we're also going to be talking about gestational diabetes and shoulder dystocia, as well as newborn assessment. So with that, we're mostly going to focus on those APGAR scores though. So we are going to have some NCLEX style questions at the end of today's session. We're going to have 3 questions instead of 2, so enjoy your bonus question today. And for everyone that is watching, make sure you share this session with your friends so they can get some review into on maternal health topics. And also follow us. We're really trying to reach 100,000 followers on TikTok by the end of this year, so help us reach that goal of the year. Follow us on whatever social media you're watching from as well though. And as always, drop any comments in the chat, drop any questions you may have as well. And once we get to those questions at the end of today's session, drop those answers in too. I'll be asking questions throughout this session though as well. But let's get started. So there are 2 different types of diabetes when it comes to pregnancy. First, we have pre-gestational, meaning it already was in existence before the client became pregnant. Or on the flip side, we have gestational diabetes, meaning it was pregnancy-induced. So the changes that happen in our body during pregnancy cause impaired glucose control. So our pancreas cannot compensate to produce enough insulin, and the result is going to be gestational diabetes mellitus. I want you guys to think of some risk factors for this. So drop what you guys think are risk factors in the comments for gestational diabetes. Let me know what you think. All right, and I'm seeing people telling me where they're tuning in from. I'm seeing someone from New Jersey, my homeland, love New Jersey, Nepal, Brazil. Thank you guys for tuning in. And don't forget to drop what you guys think are some risk factors for gestational diabetes in the chat before we move on to a beautiful table for you guys to review with. All right, I'm seeing someone saying obesity. All right, what else do you guys think are risk factors? Let me know. Okay, a lot of people saying obesity. Someone said preeclampsia. Okay. All right, someone's giving me a timeline. That timeline's going to come in later in this lecture, that 24 months. All right, I think we're mostly saying obesity right now, so let's go ahead and move on. So regardless of risk factors or not, some clients will just get gestational diabetes, even if they're completely healthy. But we do know that there are several risk factors that contribute to this diagnosis. Common risk factors associated with gestational, remember that pregnancy-induced diabetes are going to be obesity. So all of you guys were on point with that. So we want to think that BMI greater than 30. And then excessive weight gain during pregnancy. So your provider is going to tell you your expected weight gain based on your BMI, and anything over that can increase that risk for gestational diabetes. And then other risk factors are going to be family history of diabetes, a previous large for gestational age newborn, so having a larger than normal baby, and then polycystic ovary syndrome or PCOS, because that can cause insulin resistance. So now on for screening and diagnosis of gestational diabetes. I saw someone mention 24 months, and this is going to be where that comes in. So between 24 and 28 months, our clients are going to be screened for gestational diabetes because around this time, pregnancy is when that pregnancy-related hyperglycemia starts to peak. So what does this screening look like? Again, somewhere between those 24 and 28 weeks, the client will perform a 1-hour glucose challenge test in a clinic setting. What will happen is the client will arrive to the clinic without fasting, meaning they can eat and drink regularly before arriving. Then we are going to have them ingest a 50-gram glucose solution quickly. So this solution is like really sweet juice, and not everyone is a fan of the taste, especially if you're dealing with some unresolved food aversions or nausea. Everyone that I've known that has taken it has not enjoyed it. So sugar sounds great, but this is very highly condensed sugar concentration. Once the solution has been consumed, the client will remain NPO, meaning nothing by mouth. They can't eat or drink anything for an hour. Once an hour has passed, a blood glucose level will be drawn. And one thing to note with these is that these are going to be blood draws, not finger sticks. So they're going to need those venous punctures. A normal result for this will be a blood glucose level less than 140 milligrams per deciliter or 7.8 millimoles at the 1 hour blood draw. Okay, So knowing this, let's say our client result is greater than 140. When this happens, we have to confirm or rule out a diagnosis of gestational diabetes with a 3-hour glucose tolerance test. Now this test is a little different compared to the 1-hour test, so this is how it's going to go. First, the client is going to fast before taking the test. So that means they can't have anything to eat or drink for 8 to 10 hours before the test. And then a baseline blood glucose will be drawn. So because we always want to say we need to know where we're starting before we know where we're going. And then we're going to have the client drink an 100 gram of glucose solution and have their blood drawn at hour 1, hour 2, and hour 3. So that's that 3-hour tolerance test. If 2 or more of these results are over the specified threshold, then a diagnosis of gestational diabetes can be confirmed. Now, you don't need to know these values specifically. They will be provided to you on the NCLEX, but some really key points I want you to take away from this is before that 1-hour test, we don't need to fast, but before the 3-hour test, we do need to fast. And then for that 1-hour test, they're going to be drinking 50 grams of glucose solution, and that 3-hour are going to be drinking 100-gram solution. And then 2 or more elevated levels during that 3-hour test confirms diagnosis. So those are the key takeaways with that. You don't need to remember the exact blood glucose level that they need to get above. All right, that was a mouthful, but what do you guys think are some complications of gestational diabetes? So let us know in the chat. You told me what you thought some of those risk factors are, but now let's move on to some complications. Let me know in the chat. Yeah, someone said, you mean weeks, not months. That was definitely my bad. I meant 24 weeks, not months. Thank you for the correction. All right, great job, everyone. Let's get those comments in the chat. All right, good job. Okay, someone said macrosomia. Good job. All right, someone said C-section risk. Other people are saying macrosomia, infection. All right, good job. Shoulder dystocia, preterm birth, preeclampsia. You guys are killing it. So let's talk about these complications. So we are going to talk about the risks for both the mom and the risks to the baby. So starting with the baby, what you might think of most commonly is that fetal macrosomia, which is a larger than normal baby. So macrosomia is going to be a greater than 4,000 grams or 8 pounds and 13 ounces. And this can lead to shoulder dystocia, like some of you guys also mentioned during delivery, and we're going to talk about that in way more depth later. Other complications are going to be the polyhydramnios, which means there's too much amniotic fluid around the baby, which can cause complications of its own, like premature rupture of membranes and premature birth, meaning that delivery before 37 weeks. It can cause placental abruption, which means the placenta detaches from the uterus, so we worry about hemorrhage from this. And then umbilical cord prolapse, which is when that cord passes through the birth canal when the client's water breaks. And this is really bad because when that cord prolapses, the blood supply to the baby is cut off, so the baby isn't getting perfused, and this is an emergency. And then when the baby is born, risks to the baby's at risk for newborn hypoglycemia, which can sound counterintuitive, but remember that when maternal hyperglycemia can lead to newborn hypoglycemia. This happens because the baby is so used to getting all that sugary goodness from the mom, and the amount the baby can produce is usually not sufficient compared to what the environment inside the womb was producing. So essentially, they have a sugar crash when they're born. And there's also an increased risk for stillbirth with these clients. So now moving on to complications for the mom. The risks for some of those big, heavy-hitting pregnancy-related complications like preeclampsia are going to be increased. So you guys got that head on in the chat. A quick note about preeclampsia is that this is going to be new onset hypertension after 20 weeks gestation, plus proteinuria or protein in the urine, and or signs of end organ damage. If left untreated, we worry about seizures, kidney damage from the proteinuria, or clonus or hyperreflexia. And then last note about complications, there are a handful of complications that will be specific to our client with pre-existing diabetes. And these are going to include an increased risk for infection, like someone mentioned in the chat, and then possible ketoacidosis, which we learned can be life-threatening due to acidosis, meaning our blood is overrun with CO2, which can be toxic to our brain and vital organs. We're not getting perfused well. Now, nursing interventions. Before we jump into this, a quick note about the client with existing diabetes mellitus. These clients are most likely going to be followed by a specialist like a reproductive endocrinologist that will get into the nitty-gritty of insulin requirements. But we can expect, as a generalist nurse, is to teach our clients about frequent monitoring of their blood glucose, since their insulin needs may vary throughout their pregnancy. So we're going to keep this pretty simple. We don't need to go that in depth with it. Nursing interventions are going to be about the same as what we would do for a non-pregnant client, since we're just focused on that generalist nursed content. So this would be things like help in having them incorporate healthy lifestyle modifications, including a healthy diet and exercise. And not all clients are going to require insulin, so certain lifestyle modifications will do the trick for them. And then we're going to teach the client how to monitor their blood glucose per protocol prescribed by the health that require insulin. We're going to teach them how to administer the insulin and teach them about signs and symptoms of hypoglycemia and how to manage those symptoms. But what is different in the pregnant client is we need to take the baby into account too. Obviously, we're taking care of two people every time we have a pregnant client. So we are going to teach them how to monitor fetal movement and report any concerns that they may have, including changes to the fetal kick count. So if they're not kicking as much, there's less movement going on, we want them to notify us immediately about those. And since these clients have an increased risk of infection, especially UTIs and vaginal yeast infections, we're going to teach them signs and symptoms of these to notify the healthcare provider if these are observed. All right, let's go ahead and move on to that shoulder dystocia. So this is an obstetrical emergency, meaning immediate action needs to be taken because it can result in negative outcomes for mom and baby. So what happens in shoulder dystocia is the baby's head emerges, but the anterior shoulder remains wedged behind the maternal symphysis pubis bone. So in simple terms, the baby's head is delivered through the birth canal, but the shoulder gets stuck. So what this is going to look like at the time of delivery is protracted labor. And this means simply longer and slower labor than normal. This is going to key us in that the baby is not in the optimal position for delivery or is too large to descend into the pelvis appropriately, which is going to tie in with slow fetal descent. This means that the fetal station is where the baby is positioned along the birth canal is not changing. Again, this is going to indicate the baby is either too big for the pelvic anatomy or is stuck. Last thing you will typically see with shoulder dystocia is turtle sign, or the head retracting back toward the perineum. And turtle sign sounds exactly like what it is. So the baby's head emerges but then retracts in like a turtle would back into its shell. And this again is going to indicate the baby is not moving through the canal as expected and is likely stuck. So next up, we're going to have risk factors for shoulder dystocia, but I want to ask you guys what you think those risk factors are before we move on. So let me know in the chat what you guys think are risk factors for this shoulder dystocia. And hint, we just gave you one that we talked about just a second ago. So let me know what you guys think. Okay, someone said small pelvis size. What else? Good job, everyone. Good job. All right, I'm seeing someone saying that they passed their NCLEX. Congratulations, we're so proud of you. And we love that you came back to watch and give us an update on your RN journey. But welcome to the nurse world. We are so happy to have you a part of it. All right, someone said bleeding, macrosomia. Good job, everyone. All right, but let's go ahead and move on. So some patients have no risk factors at all, but there are a number of risk factors for shoulder dystocia, mostly aligned with the size of the fetus. So these are going to be that fetal macrosomia or that larger than normal fetal size, that gestational diabetes mellitus. We talked about this already, so we know this can contribute to fetal macrosomia. Then post-term pregnancy, so greater than 42 weeks gestation. So the baby is going to be growing longer than expected, so the baby can be larger in size. And babies grow the quickest in that third trimester. So again, 2 weeks can make a really big difference for fetal growth. And maternal obesity and excess pregnancy weight gain are other risk factors too, as these can lead to that fetal macrosomia. So nursing interventions. Again, shoulder dystocia is an obstetrical emergency, so we need to take action immediately and know what our action needs to be. Our goal for this is going to be for shoulder dystocia is to facilitate rapid vaginal birth. So what we need to do first is call for assistance. We are going to need some help with this. And then we are going to need to lower that head of the bed. And then we're going to assist in maneuvers such as the Mick-Roberts maneuver, which involves 2 providers like nurses. The nurses are going to each have a leg and sharply flex the thigh against the abdomen. At the same time, one of the nurses is going to apply suprapubic pressure. So pressure just above that pubic bone is applied to the fetal anterior shoulder. So the flexing of the legs is going to rotate that pubic bone and allow the shoulder to become free. And then the suprapubic pressure applied to the fetal anterior shoulder is going to help rotate that shoulder free from the pubic bone. So these movements together are going to help get the shoulders unstuck and give the best chance for a favorable outcome. Another maneuver you might see is the Gaskin, which involves having the mom move to a hands and knees position. This repositioning helps the baby dislodge from the pelvis. Other important actions are going to be to document the exact time of the events, just like we would for other emergencies like calling a code blue. So we always want to call out time reminders like 2 minutes have passed, because this will help guide the healthcare provider for interventions they need to perform. And as you can probably tell from shoulder dystocia, we can definitely have some repercussions for mom and baby. The mom can experience postpartum hemorrhage and perineal lacerations, and this can be caused by a number of reasons like uterine rupture. So lacerations can range from 1st degree, so this includes the vaginal mucosa and perineal skin, all the way to 4th degree, which includes tearing through the vaginal mucosa all the way through the rectal mucosa. So this includes the internal and external anal sphincters, so that's terrible. And then complications to the baby can be neuromuscular, like shoulder and arm nerve injury, or injury to the brachial plexus, which is the nerve bundle right under the turn from your neck to your shoulder, so around this area. And fractured clavicle or humerus, which is sometimes needed to dislodge the baby from the pelvis. And while it sounds pretty terrible for a newborn to have a broken collarbone, fortunately newborns fractures typically heal really, really well. So even though they have to get a fracture sometimes to get them out, it'll heal pretty well on its own. And then more neuro-focused can be hypoxic brain injury like cerebral palsy. And unfortunately, shoulder dystocia can even be fatal to the baby from asphyxia or lack of air. Okay, newborn care. So we are going to talk about newborn care for a baby delivered at term, so nothing before 37 weeks. So transitioning from shoulder dystocia, now newborn care. And first things first, after the baby is delivered, either bivaginal delivery or C-section, we are going to do a few basic interventions. And these are going to happen really fast, almost simultaneously. For this, we want you to remember PSDS, so position, suction, dry, and stimulate. So we are going to focus on position first. So we want to place the newborn on mom for skin to skin. In nursing school, one of the things they stress to you the most in your labor and delivery class is get that baby skin to skin with mom, and it's for a reason, because this helps with bonding, breastfeeding, and regulating the baby's temperature. And remember, they just went from a really warm, cozy environment in the mom's uterus to the body, now having a major drop in temperature outside of the body. So that was position. Now let's move on to suction. So we want to bulb suction the inside of their mouth and nose. And this is to clear out any amniotic fluid remaining in the airways. We also want to dry the babies. So this is going to help prevent that cold stress that we just said, how we take them out of that warm environment, then they're exposed to the colds. They're so delicate to temperature changes. So we want to do everything we can to keep them warm. This is the same principle as drying them off and getting them, drying someone off when they get out of a pool or a shower. Heat evaporates through fluids. So drying the baby off helps with temperature control. And then last is stimulate. While you are drying the baby, you are going to be stimulating them. So this essentially helps encourage crying and all the things we want to see to make sure the lungs are working. We want a fussy baby at delivery. This means air is moving and things are working. So we want them to be fussy. We want them to be crying. So simultaneously, while we are doing our PSDS, we are also going to be assessing the baby's APGAR score. So before we pull up the APGAR table, do you guys know what a good score on the APGAR test is? What would be identified as a good score? And I'll give you a hint, this might give it away, but it's a number between 0 and 10. What's going to be a good score? Good job, everyone. I'm seeing some 8 to 10s, 9, 7 to 10. Good job, everyone. Yeah, you guys all aced it. So APGAR is a tool to rapidly evaluate the newborn's transition to extrauterine life or life outside the womb. So the score is based on 5 variables, and it's measured at 1 and 5 minutes after birth. APGAR stands for appearance and color, pulse, grimace or reflex irritability, we got activity or muscle tone, and then respiratory effort. So we have a table for you guys to follow along as we walk through some of this. So each letter can be scored anywhere from 0 to 2 points for a max score of 10. And you guys all did so good with your answers. 7, 8 to 10 is a good score. So starting with A for appearance, we are looking for a pink baby. Blue is going to indicate cyanosis or poor oxygenation. This can either be observed by skin or mucous membranes, and we're always especially worried if we have central cyanosis. So sometimes babies are born with a little bit of blue fingers, and that can be normal as their body is adjusting to the outside world, but we're really worried about central cyanosis. And then P is pulse. We are looking for a pulse greater than 100 beats per minute, and you assess this using a stethoscope and listening and counting. And then G is for grimace or reflex irritability. For this one, you're looking for a cough, sneeze, or cry. And these reflexes are typical for neurologically intact newborns. And now A is for activity or muscle tone. So we want to be sure our baby isn't limp. We want to see some activity and spontaneous movement from them. And now for R, respiratory effort. Again, we are looking for a good breathing baby, like crying and chest expansion. We want them screaming at us. So this is going to show that the baby's lungs are expanding and air is flowing. Okay, so let's talk about the APGAR results. Again, we're going to collect them at 1 and 5 minutes. And if we get a score of 7 by 5 minutes, that means the baby's adjusting well to the outside world from the mom. And if by 5 minutes our score is less than 7, then we are going to repeat the score every 5 minutes for up to 20 minutes. A score less than 7 indicates the baby is not adjusting well to life outside of the mom and might need supplemental efforts like oxygen support. If we get a score between 4 to 6, that means the baby is having moderate difficulty adjusting. And if we get a score of 3 or less at any time, then the baby is in distress and needs resuscitation. And it's so important to note that if you ever have to do resuscitation efforts, that you do not want to do the APGAR in front of doing that. You never want to prioritize that over resuscitating that baby, okay? So always do resuscitation, never delay resuscitation if you need to do it. And also another thing to note is that APGAR scores do not predict future neurological outcomes. Okay, now we are going to move on to some questions. So we have 3 questions here today for you. And you guys have all been so interactive, but let's keep that interaction going. So the nurse is reinforcing teaching with a client who is at 24 weeks gestation and is scheduled for a 1-hour glucose challenge test. Which of the following statements by the client would require follow-up? 1, I will need to fast for 4 hours before the test. 2, the test involves drinking a 50-gram glucose solution. 3, I should not eat anything for 1 hour after drinking the glucose solution. Or 4, a 3-hour glucose tolerance test is needed if the result of this test is elevated. So guys, drop what you think the answer is in the chat. All right, seeing someone gave 3 answers, so this is only a single best. We're only looking for 1 answer. And remember to read these closely, right? So when we're reading these questions, we're looking for positively versus negatively phrased questions. Are we asking for a correct answer or something that's actually incorrect or untrue? So make sure you're reading it really closely and getting the right type of answer. All right, I'm seeing a lot of right answers coming in. We have been a little split though, so I'm seeing a little bit of every single answer in the chat right now. All right, good job, everyone. Good job. I'll give you a couple more seconds to get those answers in. All right. Well, a lot of you guys got it right. So the correct answer on this one was option 1. So for this one, with that 4-hour fasting 4 hours before, we do not need to fast before a 1-hour glucose test. We do need to fast before that 3-hour glucose tolerance test. We would fast for 8 to 10 hours before that one. We do not need to fast for the 1 hour. They can eat and drink away before that, but they would need to fast for 1 hour after taking that glucose solution. So you guys aced that one. Good job. Okay, so now moving on to question 2. The nurse is assisting during the vaginal delivery of a newborn with shoulder dystocia. Which of the following actions should the nurse take? Select all that apply. So there's going to be more than one right answer on this one. First one is prepare for a forceps-assisted birth. 2, document the time the fetal head was born. 3, request assistance from additional staff members. 4, assist the maternal client to push by applying fundal pressure during each contraction. Or 5, flex the maternal client's legs back against the abdomen and apply downward pressure above the symphysis pubis. So drop what you guys think the answers are in the chat. And something we always want you to be thinking about with these select all that apply questions are those test-taking strategies. So if you're someone like me, maternal newborn information is not my specialty, so we have to incorporate those test-taking strategies. So with select all that apply, things to think about while you're reading through is there's always going to be more than one right answer, and there's normally not going to be all correct answers. We're looking somewhere between 2 to 4 answer options here, right? And then for these, try not to compare the answers to each other because there is going to be more than one right answer. So try to go through each one as a true or false statement, right? So if we're asking about shoulder dystocia here, are we going to want to do forceps-assisted birth? True or false? Are we going to want to do number 2? True or false? So go through down the line and try not to compare them to each other when you're going through these. And another good thing to remember is that these are on a 0-1 point scaling system on the NCLEX, so you do get partial credit. So if there are 5 answer options and you only get 3 right, so you incorrectly answer 1 or 2 of them, where you say 1 is the correct answer but it's actually wrong. So if you get 3 out of them correct, then you're going to get 3 out of points awarded to you. So it's partial credit scoring, so you don't have to worry about that. All right, good job, everyone. So I saw so many correct answers. The correct answers here are 2, 3, and 5. So for this baby with shoulder dystocia, we definitely don't want to prepare for a forceps-assisted birth, because if we're trying to pull on that head with the forceps and the shoulder is stuck in there, we could actually cause more harm. So we need to reposition that baby first. And then option 4 is also incorrect. We actually want to be doing those steps in option 5. So moving those clients' leg back against the abdomen and then applying forward pressure above the symphysis pubis. So we don't want to be pushing down on the fundus. That could also make things worse. So you guys all aced that one. Okay, now we are moving on to our last question, question 3. So the nurse is assessing a newborn at 1 minute of life. The nurse notes the newborn is completely blue, has a heart rate of 110 per minute, and is emitting a weak cry. The newborn has active movement of extremities and grimaces when the nares are suctioned. Which of the following APGAR scores should the nurse assign the client? So a 1 is a score of 4, 2 score of 5, 6, or 8. Drop what you guys think. The answer is in the chat. I believe we do have a chart up there for you to read through as you're trying to figure this out. But let me know what you think. All right, good job, everyone. I'm seeing a 2, 4, and 3 so far. It seems like we're a little all over the place on this one. All right, good job, everyone. Good job. A couple more seconds. All right, I'm seeing a lot of people saying 2, some people saying 4. But let's go ahead and go over the answer. So the correct answer on this one was the APGAR score is going to be 6. So that was option 3. So for them, appearance, they were completely blue. So they're going to get a 0 on that score. Then for the pulse, it was greater than 100. So they're going to get 2 points for that. And then for grimacing, they were grimacing when their nares were suctioned. So that's going to be 1 point. And then they have active movement of their extremities, which is 2 points. And then they don't have a strong cry, but they do have a weak one. So that is going to be 1 point. So we have 2 plus 1 plus 1 plus 2, and that equals 6. So their APGAR score is going to be 6. But thank you guys so much for tuning in and being so interactive and great. Thank you for the couple people that corrected me. Again, maternal newborn isn't my specialty, but I try. And we just appreciate you guys all tuning in. So make sure that you tune in tomorrow. And then Thursday, we are doing practice question drills. So we're not going to have any lectures, just questions. So make sure you come back for those. You can see our full schedule for all of our lectures and question drills at uworldnursing.com. And you can also access a free trial at uworldnursing.com, 7-day free trial with 50 free questions. So make sure you don't miss that. Follow us on whatever social media platform you're watching from, and we will see you next time. Bye, guys.